Okay. So functional urinary incontinence is when you aren't able to get yourself to the bathroom or you're not able to manage your clothing. So then you can't hold it long enough and would have an accident. And then nocturia again is the getting up multiple times at night to go to the bathroom. More than one time is when we start kind of saying like, okay, we might want to address that. And these are some bad habits that sometimes people will get into because they're incontinent or just their lifestyle, and it can actually lead to worse incontinence. So staying dehydrated to prevent leaks. I've heard a lot of people say that they do that so they don't drink water because then they won't go to the bathroom as much. But that's actually very counterintuitive. It's not good for your whole system in general. It's not good for your bladder. So a general recommendation, obviously I'm not a physician, so I can't give everyone their recommendation, but generally it's half of your body weight in ounces of fluid per day, and it should mostly be water. There's also habitual holding, which is sometimes referred to as the nurse bladder, or the technical term is infrequent voiders syndrome. So that's somebody who just doesn't use the bathroom as often as they're supposed to.
We need the volume up. Where's the volume?
Oh, what's that? Did somebody have a question?
Where's the volume?
I think we're good. Somebody just joined the group. There.
Oh, okay.
I just muted them. We're fine.
Okay. So habitual holding is, like I said, nurse bladder or infrequent voiders syndrome. So that ends up actually overstretching your bladder, which decreases then the chance of you getting the urge to urinate. So your bladder will normally start telling your brain that, hey, I'm filling up, I need to go. But with the habitual holding and taking a long time in between emptying your bladder, that can lead to issues down the road. Fear of using the public toilet. So sometimes people will hover over the toilet seat or trying to like hold onto bars to not actually touch the toilet seat. And then that doesn't actually let your pelvic floor relax enough to actually empty. So that's a kind of a big no-no. And then also sometimes people will talk about having a shy bladder. So that's difficulty initiating urination. Sometimes that can be an underlying anxiety issue, but we also can sometimes treat that with just some bladder retraining. And then there's the just in case bathroom use. So using a bathroom because it's available, or thinking like, oh, I better go before I leave the house. Oh, I better go before I leave the restaurant, that kind of stuff. So that then ends up making your bladder get smaller and smaller, and it's not stretching to where it needs to be able to stretch to. So normal bladder capacity is about 1.5 to 2 cups is what your bladder should be able to hold. This is just a list of some bladder irritants, just for your reference. So alcohol, carbonated drinks, caffeine, coffee and tea, citrus fruit, tomato, spicy food, chocolate, artificial sweetener. This is just some of the more common ones. There's a lot of things that irritate our bladder, a lot of good things. I know I'm guilty of coffee, but these can cause you to have, if you have incontinence already, it can cause it to become more irritated and more likely to have an incontinent episode. All right. I want to talk a little bit about some behavioral techniques that we can use to help combat some of this. So there's bladder retraining. So that involves using timed voids. So that means kind of planning out your day. And this isn't like a forever thing, but to train your bladder, using timed voids. So we'll say like, okay, we're going to go at 9, noon, 3, something like that. So figuring out where in your routine that would work. And then teaching people urge suppression techniques. So just an example of that is like a sustained pelvic floor contraction can help to reframe that urge or delay an urge. And then also some diaphragmatic breathing, which we'll practice later, that can also help with urge suppression. We also want to look at treating constipation. So having constipation, having a lot of fecal matter in your bowels can actually put pressure on your bladder and your urethra. So that can lead to some incontinence too. And then it decreases the ability for your bladder to fill fully. So you're having to go more often. So we always want to look at constipation as a potential culprit for some incontinence. Weight reduction, of course, that's always helpful for a lot of things, but more weight puts more pressure on your bladder, which can lead to more accidents. And then fluid management. So if somebody has a lot of swelling in their body, especially in the lower, like in the legs, once you lay down, then it's pushing all of that fluid right to your bladder. And that can increase your chance of incontinence, especially with people have found, especially with nocturia. So getting up at night because you're laying down. So all that fluid kind of comes up. So it might be looking at different ways to manage the fluid during the day. And then a medication review in collaboration with your physician can be helpful so that you can look and see if there's anything that's giving you side effects that are leading to more incontinence as well. So this is a bladder diary. Just an example of one. I give one of these to most of my clients. So it helps us to determine the extent of incontinence. So you can see up there, you're going to look at what you're eating, what you're drinking, what times, how much you're voiding, so how much output you get. And then if you have any leakage, looking at how strong of an urge you have, and then if there's a certain activity that's leading to leakage. So like I said, it can be helpful if you're determining if there's any like dietary related incontinence. So if it's something you're eating or drinking that leads to it. And then it can also help us kind of figure out a good routine around emptying your bladder as well. These are cumbersome, but they're very helpful. I'll say that. I want to talk about the nocturia again. So that's getting up more than once a night to void or to use the bathroom. We talked a little bit about this, but some common causes can be the changing in your blood pressure or the fluid. So once you lay down, all that fluid comes up, which also goes along with renal dysfunction. If you have any of that, that could cause increased nocturia. Any sort of sleep disturbances can cause it as well. So if you're waking up a lot in the middle of the night, sometimes you'll wake up and then you'll think, oh, I better go to the bathroom. And so that can also lead to it. And then you can get into a habit. Hormonal changes. So that just changes the way that the body processes the fluids that you're taking in. And then what I mean by intake issues is we would want to maybe look at considering what time you're drinking most of your liquids. Like maybe you want to give yourself a cutoff, like, okay, I'm going to stop drinking at 7, go to bed at 9, so that your body has time to process it, so that you're not waking up to use the bathroom. So there's a nocturnal polyuria index that your therapist would calculate, and then that kind of helps determine the extent of your issue, and it's a nice way to track if it's getting better. So the biggest thing about nocturia is that it significantly increases the fall risk, especially in the elderly population. So we really want to try to keep those episodes to 1 or less times a night, and most nights of the week. This is just an interesting article I found I wanted to share with you guys about some of the behavioral therapy that was used to treat urinary incontinence. So they were using some of the behavioral techniques we talked about, a home exercise program, education, and then something called biofeedback, which we'll talk about a little bit as well. But they saw a significant reduction in urinary incontinence after 8 weeks, which improved quality of life, because I would dare say that people would be more confident in being able to go out in the community and doing what they want to do because they're not afraid of having an accident. And then the same people did a study in 2019, and they added a component of a mild cognitive impairment, and they also saw improvement. So that was interesting too, that just even with a cognitive impairment, the patients were still able to make improvements as well. So good, promising research. Another treatment option I wanted to talk about was TENS. I don't know if anybody's ever used any e-stim, electrical stimulation, but there's a couple of protocols for neurogenic bowel and bladder. So the issues we've been talking about. So how it works is it affects your sensory fibers within your bowel and your bladder, and it's used as an electric current. You'll typically set it so that you'll get a motor response and then turn it down. So it's not anything that it should not ever be painful. It's non-invasive, so it's kind of a nice treatment option. Should be set up and monitored by a professional, but we could use that to treat overactive bladder, urinary retention, constipation, and then fecal incontinence as well. So we've talked a little bit about constipation. I want to talk about how we can treat it. So exercise is a great way to get your body moving and get everything moving how it should be moving. Abdominal massage is something that we can teach to try to help move that stool around and get it to where it's supposed to go. Developing healthy routines around emptying your bowels, improving your positioning for bowel emptying. So I don't know if anybody's ever heard of a squatty potty, but I've got this picture up in the corner of a gal using one. So what it does is it raises your legs up so that you're in a better angle. So there's also that picture of the anorectal angle. So you can see when you're sitting, you're kind of compressing the rectum, which makes it harder to get the bowel movement out. But then when you're squat and you get your legs up, then it actually fixes the angle a little bit. So it's easier to let gravity help pull some stool out as well. So that's just an interesting thing. I like to advise it for all my patients. And then also you can do some postural training to try to get your postural muscles working better so that you can hold yourself up when you're trying to have a bowel movement, which can help with constipation. We'll talk, like I said, about biofeedback. So that can help train if you have any discoordination with your pelvic floor. Anxiety management. So doing some like deep breathing, doing some mindfulness techniques that can help to relax your pelvic floor. And remember, your pelvic floor is what holds it in. So if you can get it to relax, then that increases the chances of stuff coming out that you want to come out when you want it to come out. And then also looking at breathing management. So that diaphragmatic breathing we were talking about. And this is an interesting chart, just kind of shows what we're looking for with stools. So we want it to be in type 3 or 4. But if you can give me, if I were your therapist and you could tell me kind of where you're at with your stool, we can figure out kind of where we need to go with that to help you either with constipation or help you with the other end, so loose stools, and see what we can do to help it become more of a 4 or 5. Or sorry, 3 or 4. All right, so biofeedback is it's a tool that we use to look at pelvic floor function. So it uses EMG signals, so muscle signals from the muscles. It's non-invasive, so it's everything's on the outside, and it just shows how your muscles are working. So you have them on your pelvic floor and then also your abdominals. And then it makes a visual graph of your contractions so that you can see what your muscles are doing, which helps you then learn how to use them correctly. So what I really like to use it for is working on coordination, working on timing your pelvic floor muscles, working on strengthening your pelvic muscles, your isolation of them. So it can be a really helpful tool, especially just because it shows you what your muscles are doing when you can't always feel what they're doing or know what they're doing. So that can be helpful for a lot of different things. I want to talk a little bit about how we can help treat sexual dysfunction. So we can talk about strategies for easing intimacy. So positioning, environmental modifications that people might need to increase their intimacy. A lot of times there's some rigidity or spasticity that clients will experience, so we can work on managing some of that to help with success. Work on routine management, so thinking about timing and your medication effects and how we can kind of work around that to give you the best chance. And then talking about just giving some basic education, so use of lubrication, relaxation strategies, and then just techniques to improve your communication with your partner. So It's a topic that a lot of times is not discussed, but I think it's really important to consider it, and it's important for life. So I think talking about it and figuring out ways to make it better and more fulfilling is really important. And that's a nice caveat of pelvic floor therapy. So I wanted to just give you a brief overview of what like a typical treatment session would look like, a typical evaluation. So we would do a really thorough history, discussing like any issues that you've had in the past, what your life has looked like as far as bowel, bladder, sexual function, discussing what your goals are, and then talking about what your functional implications are of any dysfunction that you're having. Then we would do an external assessment of overall function. So looking at your breathing, looking at your pelvic floor function, your mobility, that kind of stuff. And then if consent is given, we could also do an internal assessment. So that's, like I said, you can hit the muscles from the vaginal or the anal canal. So if warranted and if consent was given, we could do an internal assessment to really feel what's going on. And then giving education and exercises to improve your function, and then using any of the electrical stimulations. We talked about the TENS that you could use, or using some of the biofeedback as well, if that was warranted. So that's just an idea of what to kind of expect. All right, I want to do a little bit of practicing. So pelvic floor contractions. So the caveat is, however, that doing pelvic floor contractions is not always indicated. So when I'm teaching this, I don't want you to do it for an extended period of time without an evaluation and an assessment. But it's kind of interesting to think about how to do it and using those cues. Some common compensations we want to look for are squeezing of the glutes. So squeezing your butt. We don't want to do that. That's not necessarily the pelvic floor. And then also any sort of abdominal contractions, that's technically a compensation. So we really just want those pelvic floor muscles to contract. So I might change it so I can see the participants here, if I can figure out how.
Do you need me to do anything?
I was just trying to see. Oh, here we go. Okay. So I can see people's faces.
Oh,
Or make sure you can see my face at least. So what we're gonna do, I wanted to just try a couple. So with the pelvic floor contraction, you're just gonna be squeezing the muscle. So you're gonna act like you're trying to stop urination or stop a bowel movement or stop gas from coming out that you don't want to come out. So just doing that squeeze. So what we don't want to see you like raising up out of your chair, because that would mean you're likely squeezing your butt muscles. We don't want to see that. So it should just be a gentle lift of your pelvic floor. And this is something, obviously, if you were getting treatment, we could really see what's going on, but just for the fun of practicing today. So just thinking about squeezing that pelvic floor. So squeezing the muscles around your urethra, around your anus, and then relaxing them. So that's just something to practice at home. If it seems super difficult for you, it might be a good reason to get a referral for pelvic floor therapy. And then the other thing I wanted to practice was some diaphragmatic breathing. So that's for pelvic floor relaxation, and then also some pain management. We do a lot of diaphragmatic breathing with mindfulness, just anxiety reduction, that kind of stuff. So what you're going to do for that, it's a big belly breath is what you're going to do. So you don't want your shoulders to raise up. You don't want your chest to raise up too much. So just a big calm belly breath. And then what that actually does too, it's a pressure system with your diaphragm. So when you take a big breath in, I'll show you my hand. So if this is my diaphragm, this is my pelvic floor. When you take a big breath in, your diaphragm pushes down, which also pushes your pelvic floor down. And then when you breathe out, it raises that pelvic floor back up. So that's when you can get a nice big contraction. So just practicing a couple of big belly breaths. And you might even be able to feel that when you take that big breath in, you can kind of feel that you sit down a little bit further. You can kind of feel that pelvic floor relax. And then when you take that breath, when you breathe out, you can kind of feel it lift back up. So that's a technique that I'll use a lot with my clients. Couple more slides. Okay, so reasons for referral. So all of the symptoms we've been talking about would be a good reason to look for a referral. And if it's having, especially if it's having an impact on your ability, on your ability to function. So your ability to go out in the community, your ability to get what you want to get done during the day. If you're feeling like you have to stop a lot to go to the bathroom, or you're afraid of losing your urine or your bowels, that would be a good reason to talk to a physician about pelvic floor therapy referral. Anyone that's having any pain, especially in the pelvic area, even low back pain or pain in the upper legs, or in your bottom, that would be a good reason also to maybe talk to your physician about pelvic floor referrals. And then, like we said, any symptoms of incontinence of your bowel or bladder, or the opposite, so constipation, or if you're having difficulty emptying your bladder. And then any sort of sexual dysfunction is also a good reason to talk to your doctor and open up that conversation about maybe seeing a pelvic floor therapist. And then here is a couple of websites that have some good pelvic floor therapists if you're looking for someone. So pelvicrehab.com and then pelvicguru.com. Obviously, I'd like anyone who wants to get pelvic floor therapy to come to me, but I'm also in Rockford, so that's a little far from everybody. So that's just a website to find some good trained professionals as well. And then I also included just some extra information. So the Parkinson.org PD library, I found a lot of good information with some videos and just some handouts and stuff. So more info about like the digestion, constipation, urination, and then intimacy in Parkinson's. So I really liked how they laid out that website. And then there's a couple of references. So that's it.